Yes, Greg, thank you guys so much for having me. So we're going to spend a little bit of time talking medical management of AERD and nasal polyps. I'm going to focus a little more on the AERD side, which has pretty impressive nasal polyps. We're going to talk, I actually like some of our kind of controversial discussions already. So I'm going to hit some of those up a little bit, and we can either go through it now or go through it later as well. So my disclosures, I use the word we a lot. We have an AERD center at Penn where our medical director is John Bott. So he's an allergy immunologist. He was initially trained at Scripps, who's with us. He's been practicing about 25 years. And we've got a whole host of teams. So a lot of our procedures are based on kind of that group thinking between our medical allergists and our surgical team. So let's go through AERD in its basics. So AERD is a chronic eosinophilic rhinosinusitis with nasal polyps and asthma. It is a progressive inflammatory disease despite the avoidance of NSAIDs and aspirin. And essentially what happens is the NSAIDs and aspirin induce rhinitis and asthma attacks. It's actually quite common. So this is the part that surprises a lot of people is in adult onset asthma, about 40% of adult onset asthma and sinusitis are developing this condition AERD. So it's extrapolated out to about 1.7 million people in the US have this condition. So again, your first trigger, if you have a patient who just started developing things over the last several years as in adulthood, are the people you want to think about this condition. They'll classically present with their standard CRS complaints. They'll have asthma that's either been diagnosed or not diagnosed yet, and then this aspirin intolerance. The key point of this is the timing. So from a standpoint of aspirin intolerance, these conditions develop over time. So you will develop most commonly the sinusitis first. 1 or 2 years later, you'll develop the asthma. 1 or 2 years later, you'll develop the aspirin intolerance. So you could be picking somebody up when they're early on in this triad of condition. And then aspirin interrogation can actually be a little bit misleading. A lot of patients, you ask them, do you have any allergy to NSAIDs? And they say no. Then if you ask them, when's the last time you took it? They'll say, well, I don't really take it. So this is your classic asking the patient, when was the last time you've actually taken these medications? They'll typically be diagnosed in adulthood, like I said. It's always post-puberty. They'll often have a family history of secondhand smoke exposure and then classically multiple surgeries. The key point of this, and from these slides looking at, is that aspirin and nasal symptoms continue over time despite the NSAID avoidance. So even if you say, okay, avoid these medications, which you are to avoid catastrophic complications, you really want them to understand that it is a progressive condition. Other things are very commonly known to have alcohol-induced issues as well. So there's a number of conditions, including obviously normal patients, CRS, allergic asthma, but AERD is the most common condition that you'll see some intolerance to alcohol. And their actual nasal endoscopies are usually pretty impressive. I mean, they typically have pretty impressive polyps going through there that you'll see. They're classically not infected. Again, they can have infections, but there's not so much infection. You'll see a lot of allergic mucin, similar to what you see with AFS, but typically not infections. And then the polyps are going to recur very quickly. So if you have a patient that you operated on and you really saw these polyps come back very quickly, or they have really challenging asthma on top of this, just think about this condition as a possibility. This is my only slide on the science, but essentially it's a dysfunction of the arachidonic acid pathway where the aspirin and NSAIDs block that anti-inflammatory pathway and push you to this pro-inflammatory pathway. And this is essentially what causes these conditions. And it's all COX-1 inhibiting NSAIDs, highly selective COX-2 like Celebrex and things like that will not have a reaction, but most other ones will. And typically they can take Tylenol safely, but at higher and higher doses of Tylenol, they can have a little bit of low reaction. And then this is really what I want to highlight is the key is really asking every patient these questions. So if they are adult onset, really ask them, interrogate that NSAID question. And if they haven't taken any, that's where you still want to think about whether they need an aspirin challenge or not. And again, I said avoiding aspirins are going to avoid catastrophic events like sending you to an ER with an asthma attack, but it's not avoiding the progression of the disease process. Treatment from a big picture standpoint, just like all polyps, is very similar. Corticosteroids, leukotriene modifiers, and then complete sinus surgery, which we're going to hear up from Dr. Sindwani next. And then from our end, the primary, and we'll go through this with the age of the biologics, but primarily post-surgical aspirin desensitization. So typically, we talk about aggressive sinus surgery. This is to remove all inflammatory burden in the sinus cavity. Aspirin desensitization does not reduce polyp burden. So if you do surgery, a bunch of polyps come back. If you try to take them for desensitization, it will not work for you. You really need to have that inflammatory burden down. And then about 4 to 8 weeks later, you do the desensitization. You keep them on long-term aspirin. In general, your tenets are going to be preoperatively, you want the asthma itself optimized. You want patients to be medically stable. And then you really do want to reduce a lot of the inflammatory burden. And you're going to see my first one here. You look at the slide. I got that middle turbinate reduced there. So I typically, on these type of patients with this severe disease process, I have found my goal in life is to get topical access and topical steroids into this cavity. And so anything I can do to reduce the amount of, reduce the surface area there for that is going to help me long term. And then post-op, it's a slow steroid wean that we're going to do right up to the desensitization. And typically most of these patients do well. So what desensitization is essentially after surgery, again, 4 to 8 weeks later, they'll go, at least in our center, they'll go to actually a surgical bay. So this is a bay in one of our peri-op surgery centers. And our allergists will typically do about 4 in a day, where essentially they start with a escalating dosage of initially intranasal ketorolac, and then they'll continually slowly go up in escalations till they switch over to PO aspirin products, again, from a lower to higher dosage. Anytime they have a reaction, and they all have IVs and access, and there's a nurse there as well. If they have any reactions, either that they can feel or the PFTs demonstrate that there's any bronchoconstriction, they'll get treated for that accordingly with your antihistamines, your epi, whatever you need to settle that down, and then they'll continue up the track till they're at a full anywhere from 650 to 1,300 a day. Most of our patients will end up with a total of 650 milligrams of aspirin post-op, where they'll take a 325 in the morning and 325 in the evening. And then as they do well, we'll drop them down to about 325 total. The data has shown that's about the lowest, minimal effective dosage is 325. So lower than that, it does not seem to be protective from reducing the risk of polyp recurrence. We have a center, and it's interesting. This is going to be kind of obvious data, but it was very interesting for us to actually see it. That allergist we showed, John Bosso, he actually initially worked about an hour and a half away from us. So we would do surgery. We then send it to him. He'd been doing desensitization forever, do the desensitization, and then we'd see how these patients did. And then in 2016, we actually pulled him over to our center just because we were kind of high volume of these patients. And then we looked at our data when we were before him and after him. So before him was in the orange, and a couple things you see. This slide, this is not statistically significant here. You see the reduction in how the patients are doing in their snot scores. But then what you see is, they were slowly drifting up afterwards, and they were holding, but not as well as we would like to see them. But then after we brought them over, and that's the blue line, then you actually see this really nice drop, and we've followed this out for much longer. And basically, we've been getting durable results here for long-standing results for bringing them from that kind of mid-40s, 50s down to about that high teens as far as their snot scores. And accordingly, reduction in steroids and reduction of revision surgery. So a big portion is not just the surgery, it's not just the desensitization. I think just like we've seen in other multidisciplinary clinics, that coordinated care does help. So wherever you are doing this or thinking about the procedure, the take-home message is you have to be close with that allergist who's doing the desensitization. If it's one of those that you don't have that close coordination, you're just not going to get the same outcomes. But I think it highlights the fact that compliance is a big issue on these patients and close discussion. It's close evaluation. And this is the same thing. We've shown that really after this desensitization and surgery, there is a huge reduction both in oral corticosteroid use and inhalational corticosteroid use. So then switching gears a little bit to biologics, as this is always a question that comes up. So this was a discussion article that just came out in JACI just a couple months ago with Tanya Laidlaw, where they basically were looking at, from an allergy standpoint, when should we be putting patients on biologic? This is the million-dollar question. So this is specific to AERD still, so not just nasal polyps in general. But essentially, what they want to do is create an algorithm, and you take a look at this. So, you can look at this algorithm. Nasal polyps, you're going to think about surgery. Where you would think about maybe not having surgery and having the biologic is Do you have other conditions? Do you have this chronic spontaneous urticaria, which is approved for biologics? Do you have atopic dermatitis, eosinophilic esophagitis? Or in our condition, the one thing we've had where we've had some patients where I'd like to take them to surgery where we haven't been able to is if they're uncontrolled severe asthma. So those are patients that are high dose prednisone more for their asthma. But if you go away from those, then you think about, okay, is there any contraindications to aspirin? If there's not, we are typically taking those patients to surgery and then desensitization afterwards. And if there are contraindications, again, think about biologics. Just for the interest of time, I don't have the slide, but for ours, I mean, I cite when our patients ask what percentage of our AERD patients go into biologics, it's about 10%. So 90% of our patients are showing long-term durable results. There's about a 10% where half of them have some intolerance to the aspirin, whether it's like GI bleeds or some issue from gastritis, and half of them don't respond well. And those are the patients we typically switch over to biologics. But it is something to consider. I mean, I think anyone who reads about this understands there is a tremendous cost to these biologics. Who exactly is burdening the cost is still up for debate between all the different biologics and the moving target, but they are expensive. In the last few minutes, these slides are interesting to me. So John Basso, again, these are his slides. So if you ask me anything off these slides on the biologics, I'm not going to know the answer. We can call him in and ask him. But I joke, he makes me a much better surgeon. And when he smiles and says yes, I'm like, all right, just so we're clear, I make you a much better allergist. So just quid pro quo. Dupilumab is the one. Thank you, Dupilumab, for sponsoring this. They are they were the first one that were indicated for nasal polyps. Monoclonal antibodies for IL-4 and 13.
Just give it 1 minute and it'll be fixed.
Yeah. Omalizumab, which is Xolair, which is an IgE binding, and then mepolizumab, which is your Nucala. So I always struggled with this, like how are we figuring out how to use these? I mean, quite honestly, I don't know, and I don't prescribe biologics. And I think, honestly, the allergy group was also really struggling with this, but now they are trying to, finding some nuances into what seems to work better. So again, these are his slides and what he thinks about. So when he thinks about dupilumab, he's thinking of patients with higher tissue eosinophil levels. So all our tissue after surgery is going in for evaluation of a number of different factors, including eosinophil level, comorbid eosinophilic and or steroid-dependent asthma. If he's got high nitric oxide levels when he's checking that, and then if he's got comorbid eosinophilic esophagitis, or atopic dermatitis, because again, it's approved for those as well, so you're essentially killing two birds with one stone. And then for us, this is the big one for most of our AERD patients are refractory to our kind of standard of care. And then factors against it. If the peripheral eosinophil level is very high, they don't use that. And then if you have suspicion for EGPA, so EGPA, it's interesting. It's one of those conditions that if you don't look for it, you don't see it. But your patients who have severe nasal polyps who also are very steroid dependent, and they just can't get them down off steroids. We think about EGPA. Obviously, the number of other factors you can see here that you want to look at and ask these type of questions because these are conditions that can be pointed to for EGPA. And then not published, but he has anecdotally, the patients that he sees that tend to have a little more of these autoimmune kind of disorders in the family, he has noted a higher level of myalgias and arthralgias in those patients, so he hasn't used them quite as much for those patients, or at least is a little more careful on that. Now, Xolair, the factors for this is, think of it more a little bit like allergies. So patients with strong allergy test to perennial allergens, patients with high total IgE levores. For us, a lot of our AFS patients, so the allergic fungal sinusitis, obviously we've traditionally taught immunotherapy to the fungal the molds. He's using this in that situation a lot as well, and they seem to do quite well. And then same thing, patients with a lot of central compartment atopic disease, which again are very allergic, right? And then also it is indicated for patients with spontaneous urticaria as well. So those patients can get kind of, again, a double hit with this. And then also patients with planning for pregnancy. I think it's a Class B pregnancy. And then you can, again, read up on here which ones he's going to go away from. But basically, this predominantly late onset eosinophilic upper and lower airways, he's going to avoid that Xolair. And then the last one's Nucala. Patients that he likes Nucala for, again, peripheral blood eosinophil levels that are very high. And then patients with systemic diseases. So EGPA, this is the main indication for EGPA. And this medication, the dosage that's cited there is a higher dosage than for standard patients. And then with that history of eosinophilic pneumonia, and then factors against it are, again, that kind of allergic IgE, essentially the factors that he's looking at for the other two biologics. So in summary, thinking about AERD and nasal polyps in general, you do need this complete surgery, and that's followed by that aspirin desensitization in the AERD patients. And that's going to be the most effective way to control aggressive CRS with nasal polyps. Both in AERD and severe polyps, you need an aggressive therapy for these patients. Otherwise, we're just going to fail. The post-op medical component needs to be hammered home for patients. And then obviously regarding biologics, it's fascinating to have this in our armamentarium. I remember when I started in 2010, the number of patients that just lived on oral steroids, 5 milligrams, 10 milligrams, 10 every other day. You just don't see that anymore because of the option of biologics. So it's fantastic. I think we just have to figure out what the right level for those are. Thank you.